So my original topic or title for the topic was a global perspective on APOL1 genetic testing. That part of the story kind of fizzled out. So this is just the Seattle perspective on APOL1 genetic testing. So the goals of the talk this morning are to renew emphasis on APOL1. Ashley Jefferson in our division gave a grand rounds on it last year, going over the basics of pathophysiology and disease association. So I'll try not to repeat too much of that or steal too many of its slides. But I will review briefly some of the geographic distribution of APOL1 and try to understand some of the gaps in knowledge of the absolute risks associated with the variants, which I think is a big part of the difficulty in interpreting tests results and conveying results to patients. I'll describe some of the current genetic testing options in the US, and hopefully this talk will make testing more accessible and, if nothing else, normalize the discussion about APOL1 with patients. And then I'll finish up with a brief mention of some of the what APOL1 testing could involve in deceased donor transplantation, particularly in the scoring system for that. So APOL1 is the gene that encodes apolipoprotein, and the variants that have been associated with kidney disease there's what are considered two high-risk variants. One is termed G1, which is actually the combination of two separate missense variants, and then the G2, and these are always inherited together. And then the G2 variant is a deletion in the C-terminal part. Both of these variants involve this serum resistance associated binding domain of the protein. In the distribution of the various combination of these variants in African American populations is surprisingly relatively consistent. About half of people will have the so-called wild type version of APOL1. About 37% will be carriers for either one, or heterozygous carriers for either the G1 or the G2 variant. And then about 13% will either be homozygous for G1, homozygous for G2, or compound heterozygotes where they have one copy of G1 and another copy of G2. And these all seem to convey roughly equivalent risk for a variety of kidney diseases. In 2003, APOL1 was identified as an important part of the innate immune response to trypanosomal infections that cause sleeping sickness. So APOL1 will circulate as part of the HDL complex, get endocytosed by the parasite, and then the APOL1 protein inserts into the lysosomal membrane where it forms a cation selective pore, allows sodium and water influx into lysosomes, causes lysosomal swelling, and it dies. So a subspecies of trypanosomes, TB rhodesiense, has evolved the serum resistance associated protein that blocks the ability of APOL1 to fuse with lysosomes. So this is sort of a parasite response to the protein. The APOL1 variants that are considered high-risk variants for kidney disease that involve the part of the protein that interacts with this SRA protein from the lysosome actually prevent the binding of SRA to APOL1, so they allow it to continue to insert into the lysosome and be protective against trypanosomal infections. There is the distribution of the high-risk variants really is highest in regions in West Africa, basically. The darker colors represent higher frequencies of the higher risk genotypes. I'd also point out that it's found in parts of the Caribbean and in Latin America, in addition to the United States and North America. Parts of Africa, these, interestingly enough, are not the distribution of the genotypes in Africa is far from uniform, and there's a lot of variation within Africa itself. APOL1 is present in U.S. Hispanic populations in a survey of 12,000 sort of randomly, haphazardly selected Hispanic households in the Bronx, Chicago, Miami, and San Diego that was, quote unquote, healthy and not enriched for CKD patients, had a prevalence of 2 high-risk variants of 1% in patients that are people that identified as having Caribbean ancestry. If they had mainland Latino ancestry, the frequency was 0.1%. And again, within Africa, a lot of East Africa has relatively low frequency of the high-risk alleles, where the highest frequencies are focused around West Africa. In 2010, the variants, the high-risk, what we currently consider high-risk variants, were associated with a variety of kidney diseases, and the relationships are strongest for HIVAN, where the relative risk is somewhere between, or the odds ratio is somewhere between 25 to 50. For FSGS, the odds ratio is about 17. For quote unquote hypertension associated ESRD, their odds ratio is about 11. And for transplant allograft failure, lupus nephritis as a cause for ESRD, and non-diabetic CKD progression, odds ratios are about 2. COVID-related AKI has recently been identified also as being more frequent in high-risk variants, and the odds ratio for that is also about 2. This is data from the Million Veterans Program looking at AKI in hospitalized patients, and for stage 2 and 3 AKI, the odds ratio was 2 in high-risk variants compared to low-risk variants. Now, what's these data all derived from cross-sectional studies, converting odds ratio data derived from that to, what patients want to know is what's my lifetime, what's my personal risk of developing kidney disease or kidney failure. That's a little bit difficult. So, what the lifetime risk of any of these variants is sort of unclear. There is a publication from 2015 by Doomer et al., where they estimated an 11% lifetime risk for ESRD caused by hypertension, and a 4% risk for FSGS in the setting of 2 high-risk variants. They don't really explain their data or how they came up with these numbers very well, but from this article, review articles kind of quote a 15 to 20% lifetime risk. I think a few extra percentage points are thrown in for lupus and other causes of ESRD. So this is quoted frequently. The basis for it is not super strong or data driven. So a 20% lifetime risk for a condition that is at least in part genetically determined is considered relatively low penetrance. So it's why that the high-risk variants are really considered risk alleles rather than strictly monogenic disease. The same authors estimated a 50% lifetime risk for HIVAN in untreated HIV infection, and they derived a population attributable risk figures for 2 high-risk variants ranging from 52 to 68%. There's not a lot of incidence data, but there is some. The ASK cohort, a subgroup of that, the almost 700 patients underwent genetic testing, and over 9 years of follow-up, having 2 high-risk variants was associated with a hazard ratio of 2.1. So you can look at the most recent USRDS data from 2021, looking at the incidence by race/ethnicity, and the self-identified, self-reported Black patients have an incidence rate for ESRD of 964 cases per million population versus the white population of 252 cases. So that's obviously at first glance more than 2, but how much of that increase might be associated with the high-risk variants themselves? So if you make the assumption that the proportion of the African American population with 2 high-risk variants is 0.13, then 0.87 of the total incidence of 964 per million, this is comprised of a population that of 87% that have sort of a baseline risk, and then it's another portion that has this increased risk that's associated with the high risk variants. So if you solve for X, this would propose that this baseline risk with 0 or 1 high risk variants is 838 per million. And if there's 2 high risk variants, it's 1800 per million. From that, you can calculate a population attributable risk of 46%. If instead of this 0.13 assumption, use this data from the original 2010 paper that made the association between APOL1 and high-risk variants, in that paper, the prevalence of the high-risk variants was 0.46 in ESRD patients, not 0.13. So in other words, enriched for the patient. So if you use that figure, then the population attributable risk is 29%. So maybe these would give you sort of a range. And again, I should point out, I'm ignoring for the moment that a hazard ratio is not the same as an incidence risk ratio, but so I would consider this sort of like rough estimates. And you can compare that with the attributable risk for smoking and lung cancer of 80%. So in other words, somewhere between a third and half of the risk associated with smoking can be chalked up to the risk variance. There's a article in the New York Times a couple years ago. One of the comments in that kind of struck me. It was referring to 2 brothers that had lupus nephritis, and the statement was made, but their kidney disease may be caused by a gene, not an autoimmune disorder. So I would say that that's not entirely true. The genes certainly play a role, but there are obviously lots of other factors, possibly other genes, social determinants of health that are also important. Bessie Young in our division in 2017 was lead author of a review study that went over some of the issues with clinical genetic testing for APOL1. I've kind of adapted that and updated a few things in this. So for the healthy population, she drew up this pros and cons table, which I like. So for the healthy population, reasons to pursue genetic testing might be that if you had a positive result, it might, in theory, stimulate better health behaviors, better attention to blood pressure, weight, diet, etc. It might increase the monitoring for CKD, and it might offer some peace of mind if the results are negative. Cons against testing, again, a lot relies on the vagueness of what the results mean and what is the absolute risk for kidney disease in someone with a positive result. It might increase anxiety or fear in the individual, and it might just be another aspect of stigmatization or another black mark on the record for someone that they don't necessarily know what to do with. And it, in theory, might impact life, the ability to get life and disability insurance. It would not prevent health insurance, but there's legal protections for that, but not for life and long-term care insurance. In the transplant setting, it potentially could better refine the risk scores for deceased donors and for both living and deceased donor recipients. It adds to their sort of right to know about the risks, future risks for the graft. The cons against it are that the future risk for the graft is still a little bit uncertain, especially in the living donation setting. There's a large study called the APOLLO study that finished enrolling last year. The results of that are still pending. I'm not sure exactly when that will come out, but I think will answer a lot of the questions in the transplant setting. And for patients with CKD, reasons in the pros column would be there are actually now are potential therapies on the horizon. There's two ongoing clinical trials looking at therapies. The cons are that those are not available yet. We don't know necessarily that they're going to work. And there's also some uncertainty as to the impact of the general CKD measures like RAS inhibition in the setting of two high-risk variants versus 0 or 1. There's some publications reporting patient attitudes towards APOL1 genetic testing. For the most part, they're positive. Should remember that these are sort of self-selected patients that are interested in participating in focus groups and that kind of thing. So it's sort of a selective population. But in this paper from St. Louis University, 16% they predicted they would be very upset if results are positive. So I think that's something to keep in mind when you're discussing testing with patients. And from another paper where Bessie Young was a co-author, I was struck by this statement. In fact, this was in the title of the paper, and the statement made by one of the focus group participants was, "Why are we not knowing about this? I know you have to do research before you come out with anything, but it's been a while and still no one has heard about it." And this is from 2019. And 5 years later, I'm still struck by, even like the number of medical students and residents you talk to that are sort of at best maybe vaguely aware of what APOL1 is, much less patients. This paper on the focus, reporting the results of the focus group, 64% thought it should be offered to everyone. 21% thought it should be limited to people with CKD, at risk for CKD. A minority, 10%, thought it should be limited to only those with CKD. 100% agreed with testing deceased donors. 100% were opposed to mandatory testing of living donors, but felt that it should be optional. If you're ordering testing, you should do some degree of pre-test counseling, which is a little different than other tests you order like CBCs. And common issues that come up are potential cost, the lack of easy availability for testing resources. You should go over what's known about the natural history of APOL1 mediated kidney disease. And you should stress that the majority who are positive will not develop CKD. So being diagnosed with two high-risk variants is not equivalent to being diagnosed with the disease. And you should emphasize that there's still a lot that's not known. The biology is still under study. It's worth mentioning there's a potential to take part in clinical trials. We have to be careful not to oversell this. And you should point out that there's a potential negative impact on life and long-term disability, long-term care insurance. This would mostly apply, I think, to healthy patients. If patients already have CKD, then there probably wouldn't be additive impacts of a genetic testing result on that. And then if you receive once you receive a result, you should sit down. If there's a positive result, you should really sit down face to face. I suppose if it's negative, a phone call would suffice. I'm not going to go through all these in detail, but you want to explain in detail what the recessive mode of inheritance means and what the risk to their offspring and to relatives and to the risk to relatives. So if the person that you're testing has two high-risk variants and their partner has two high-risk variants, then all of their offspring are going to have two high-risk variants as well. And the range of possibilities are from that to if they only have one high-risk variant and their partner has no high-risk variants, then 50% of their offspring, or each offspring will have a 50% risk of being a carrier and a 50% chance of being unaffected. Barriers for providers for ordering APOL1 genetic testing. It's not an EPIC test, so you can easily order like a CBC. It's kind of a pain to order, to be honest. There can be uncertainty, at least in the past, about costs and patient responsibility, exactly what it's going to cut, what the out-of-pocket costs might be to patients or what insurance is going to cover. And then again, the uncertainty of the clinical relevance of what results mean and what it means in terms of absolute risk for the patient. And then also there's concerns about, is this just another black mark or another form of stigmatization? So I've tried to come up with sort of example script in bringing this up with patients. And you can see what you think about this. There's a gene that explains some of the increased risk for a range of different kidney diseases in people with African ancestry. They're working on treatments for this, but nothing is available right now. Would you be interested in this? It can be a blood test or a saliva test, and the company that makes the drug being studied to treat it is paying for the testing. So you can order APOL1 testing if you search APOL1 genetic testing. The first hit is this website that is run by a manufacturer of a drug that's being studied in clinical trials. There's 3 different testing options. Arcana Labs that does all the kidney biopsies, and Arkansas can do testing on blood, saliva samples, or paraffin block samples from kidney biopsies. LabCorp is not available in Seattle. And then you can order testing through Natera, also with blood or saliva. And the attractive part about that is that these other 2 labs just do single gene testing for APOL1, whereas with Natera, you get the Renocyte panel that includes testing for 385 other genes. So for the free testing, there are eligibility criteria. The person has to self-identify as Black, African American, Afro-Caribbean, Hispanic, or Latino. Their CKD is they have to have CKD, and it's not felt to be due to diabetes. Unfortunately, dialysis patients or transplant patients are excluded. You can either order these little kits ahead of time that maybe makes it a little easier for the lab, or you can go to the website and print the form. And one thing to remember is you need to have the patient sign the consent form to include with the sample. And then in Epic, you just enter lab undefined and you put in the comments APOL1 genetic testing to Natera. The labs at Harborview and UW are basically the send out process and everything to Natera. So that's pretty much all that you have to do. It uses just 5 cc's of whole blood and an EDTA tube if you want to enter that too. So again, these are paid for by the company that has made Anaxaplin. Ashley spent more time talking about this on his grand rounds last year, so I'm only going to mention this briefly. But that's a drug that led to a 47% reduction in proteinuria in 13 patients over 13 weeks. The KRI and university is a site for the Amplitude study. That's the phase 3 extension of the study that's enrolling. The study that was published last year was limited to FSGS patients. This is enrolling all proteinuric CKD patients from age 10 to 65. They can't have diabetes. The outcomes are eGFR slope and proteinuria. If you have patients that might fit this, contact Ashley. Another variant that's been identified in APOL1 is worth mentioning, and it's again limited mostly to patients with African ancestry, and it's relatively common, like 2.6% allele frequency. And instead of involving this SRA binding domain, it involves this part of the protein that's involved in the ability of it to incorporate into membranes and form cation pores. And it turns out that the presence of this variant, where it's a missense variant, where asparagine is substituted, or where lysine is substituted for asparagine, it reduces the risk of CKD and ESRD. This is a cohort from the Million Veterans program, where if you had 2 APOL1 high-risk variants, your odds ratio for CKD was 1.7, and odds ratio for ESRD was 3.9. But if you had the APOL1 high-risk variant and you also had this N264K variant, then your risk for these outcomes was really the same as for the low-risk variants. So basically negates the impact of the high-risk variants on outcomes. So among the miracles of modern medicine that I would think about, HIV was discovered in 1983. 4 years later, a therapy was developed. 13 years later, a good therapy was developed. Uh, COVID was identified in January 2020. 11 months later, a vaccine was developed and released, which I think is pretty amazing. In 2010, APOL1 genotypes were linked with CKD risk. We might be on the cusp potentially of a therapy in, I don't know the time frame, maybe 2 to 4 years from now, if the if the amplitude trial pans out. What's not a miracle of modern medicine is that in 2016, APOL1 high-risk variants were identified as important in predicting deceased donor risk. That unfortunately has had no impact on donor risk scoring. So race is one of the factors that are included in the kidney donor profile index scoring. The KDPI, Kidney Donor Risk Index, was developed in 2009 with the idea of better matching kidney and recipient survival likelihood. They've been used since 2014 in the revised kidney allocation system. Prior to that, there was this binary extended criteria donor designation system. The KDRI score is composed of 10 items, one of which is ethnicity, and by that it's African American or not, and those are used to compose a continuous score. And the KDRI score estimates the relative risk of graft failure compared to a median risk donor. The KDRI values are then mapped to the previous year's transplant data to produce a KDPI score, which ranges from 0 to 100%, with lower scores indicating better predicted graft survival. So in other words, if a score is 85%, it means 85% of kidneys have better survival probability. A related issue is that 20% of deceased donor kidneys are discarded. A group from UW that included Nikolai Leka published that a KDPI score of greater than 85% results in a 45% discard rate. So this scoring system is predictive of discard rate of deceased donors. A group from Hennepin County Medical Center, where the SRTR is administered, used the SRTR data from 2015 when the revised kidney allocation system came into use from 2015 to 2021. And using the current scoring system, 11,604 donors during that period had a KDPI of greater than 85%. And that comprised 31% of total African-American deceased donors. If the race factor was removed from the KDRI scoring, a slight increase, 11,659 donors would have a KDPI of greater than 85%, but a dramatic reduction in the proportion of African-American donors. Because it's sort of this scaled percentage of all donors, if you reduce the KDPI score for African-American donors, it's going to result in an increase in the KDPI scores for non-African-American donors. So it was predicted to reduce the discard rate of African-American donors by 353, but it would increase the discard rate of non-Black donors by 385. So actually slightly more, or roughly the same. High-risk variants have been identified since 2016 as being important predictor of graft survival. In 1,100 deceased donor transplants from Emory and Wake Forest over a median follow-up of 3 years, the hazard ratio for graft loss with 2 high-risk variants was 2. A similar group looked at the effect of replacing the race factor in the KDPI with the APOL1 genotype. And so this was looking at 600 donors from Wake Forest, Emory, and UAB. So in using the current system, the African-American donors was 0 to 1. Risk variant had a KDPI of 71% on average. And if they had they had two high-risk variants, 69%. If they instead replaced the race score with the APOL1 result, then it changed the African American donors to basically an average kidney instead of where 71% are considered better. It was basically an average kidney. And if there were two risk variants present, then the KDPI increased to 88%. So this is important because this is only, roughly 13% of the projected donor pool. And so 87% get reclassified to a more favorable KDPI score, and it more accurately portrays graft survival probability and potentially could reduce the discard rate if you move to this scoring system instead. So in summary, APOL1 high-risk variant frequency is about 13% in the general African-American unselected population. It's lower if there's East African ancestry. It's also present in Hispanic populations. The presence of two high-risk variants represents an increased risk for diverse kidney diseases. The absolute risk for CKD or ESRD outcomes remain uncertain. It might be in the range of 15% over a lifetime. Free testing is available for eligible patients. Testing results should include information on the N264K protective variant. Deceased donor transplantation should eliminate the race term in the KDRI scoring and replace it with APOL1 genotype information.
All right, thank you so much for that. That was really very interesting, Brendan. And sorry, I know we kind of ran over time a little bit today. Maybe we have time for maybe one or two questions before we kind of move on. Any questions, anybody?
Yeah, I have a quick question. So, can you comment on the kind of genetic testing for patients who have had prior biopsies? Is it possible to test those biopsies, and is it something that we can expect in the future to be done more routinely?
It's possible to do genetic testing from paraffin blocks. I don't know, with the issue of consent, I guess, for testing. If there's a sample that's available and the patient consents to it, sure. I'm not sure if that would be, become a routine part of what pathologists do.
Okay. Any other questions, anyone, or anything in the chat? All right, well, if no other questions, we're a few minutes over, and so thank you for tuning in, everybody.